Great. Well, welcome everybody. This is a question and answer session for GU cancers. I'm David VanderWeele. I'm a medical oncologist at the Robert H. Lurie Comprehensive Cancer Center at Northwestern University.
My name is Russell Pachynski. I'm a medical oncologist at Washington University in St. Louis, specializing in GU cancers.
All right, and so we are going to be answering questions as they come in from the chat. And so I think there's already been a number of questions coming in, but feel free to add more as they come in. I think there's, understandably, there's been a lot of interest in the vision question. And so the first question is about that study and commented that it's a hugely positive study. Any idea when we may get FDA approval? Unfortunately, I don't have an inside track on that. Just a week and a half ago or so, it did receive breakthrough designation from the FDA. Which I think just means that there's a lot of interest and they're going to try to be ushering this through. I would expect at least by the end of the year, but I don't know. I've heard some whisperings that it may even be within a couple of months, but I'm not exactly sure when that approval will be coming. I think I also saw some questions about sort of delivery of the therapy. How is it given? And I think, as I kind of referenced, I think this is a complicated therapy that does require, well, we'll see what the FDA approval says, but in the study, it did require PSMA PET scans beforehand. To make sure that you're eligible, as well as coordination between medical oncology, nuclear medicine, radiation oncology. And I think that probably depends on each institution, how exactly they will handle that coordination and who gives it. At our institution, it's given by nuclear medicine, but I'd imagine at other places it may be given by radiation oncology. And it did take some coordination. I mean, you get the therapy delivered. You have to do some evaluation to make sure that the dosing is correct, which the vast majority of the time was okay for us, but occasionally we had some issues with that. And so it does require significant coordination between all these different groups. And so I think, with this positive study, a lot of places are working on getting this up and running, but it's not just sort of flick a switch and you're good to go right off the bat. So I think it will, especially initially, probably be more limited availability, but hopefully that improves over time as we all become more familiar with this. So I think the next question maybe is for you, Russell. And I think this is referring to the bladder information data that was presented. Very impressive ongoing responses with GemCis plus Nivo. Is this ready for prime time?
Yeah, good question. I think it's, I mean, there were, I think, very good responses. I think it's still a little early. I mean, we're still at about 2 years for the maximal follow-up. I think around that time frame for this data set, and so I think it's a little early to say from that perspective. And the numbers of this trial, looking at essentially 30 patients that in each arm that had a CR or no clinical CR, and so as we all know, the smaller the trial, sometimes you can get these nice response rates that don't end up playing out in a larger phase 3 randomized trial. And so I think probably not yet, but certainly a good foundation for a larger randomized trial. But it is, and I guess there are bladder sparing options in patients that aren't good cystectomy candidates. So is this, is this something you could do? Well, I certainly wouldn't recommend doing an off-label type of thing, certainly, combined with radiotherapy, which is not what this was looking at, those patients that aren't good cystectomy candidates, definitely something to think about. But bottom line, no, not yet.
Yeah, it's sort of following up on what you said. I think there was quite a bit of interest at ASCO, or a number of studies looking at bladder sparing options, or non-cystectomy sort of neoadjuvant immunotherapy. Do you think complete response to systemic therapy is likely to be the way to go for bladder sparing, or are we? I mean, chemo plus radiation, would be the standard bladder sparing approach right now. It seems like that might be difficult to improve on. I don't know. What's your thinking on that?
Yeah, I don't know. It's tough because there are, the neoadjuvant studies, where they still are doing the cystectomy, those are, you're still getting a cystectomy, right? So it's I think it's difficult to say, but I think the I think with the, and then another thing that is, can a multimodality approach be taken? Can chemo, radiation, and immunotherapy in a bladder sparing setting be taken? Right. I think we just don't have those data that look at how best to approach this. So this is one where they're just saying chemo, add that on and see if we can continue to monitor. And I think from, I think from the data, having IO up front is my guess is probably going to be the way to go. It's useful in the maintenance and later settings. But I think we will get to a point where we will have more successful bladder sparing options.
Yeah, the SWOG, I think it's 1806 study we're participating in, which is that chemo and radiation, and then half of patients also getting immunotherapy, sort of getting at that, the full multi-modality approach. Interesting to see what that looks like when that data becomes available. So next question, I think we're getting back to the vision study again for this one. How expensive is All right, that's a very good question. I don't know the answer to that. Obviously, the therapy was paid for by the study on the trial. It is a new therapy, so bound to be expensive. I don't know if it will kind of be in line with radium-223. Also kind of a monthly therapy, although in Vision it was every 6 weeks, also given by nuclear medicine or radiation oncology. But really, I have no idea what that's going to look like. I think that is sort of getting back to the earlier question or discussion. That's just another part of, what's the availability going to be. From what I've seen, there's a ton of patient interest. How available is it? I'm not sure. I do know folks who have gone to Germany to get therapy. It's approved there, and from what I've heard, they're, at least from one patient, they're paying about $3 a shot. Sorry, they're paying about $3,000 for a treatment.
$3 is a bargain, although 3,000 is actually not that bad.
Yeah, 3,000 is also a bargain.
Yeah.
I'm not imagining that will correlate with what the cost will be here in the US, but I don't know.
Yeah,
We'll have
I
to see.
mean, do you remember when, when CYP first came out in 2010, FDA approved, and people, and it's not a cheap treatment, right? It's $30,000 essentially a pop. But now in the age of modern immunotherapies and fancy targeted therapies like this, you know, those types of costs seem reasonable for a short course. I mean, some patients who are on immunotherapy, as everyone knows here, can be on the therapy for quite a long time, and so I think that's a real concern, the financial toxicity. But this at least is a defined number of doses, so that's, I guess, the good
Yeah.
news.
Yeah, but I think that may also be sort of the rationale for being able to charge more. I don't know. It's a cynical
Yeah.
viewpoint, I guess. There's a follow-up question about vision, about a situation about where you may have too much bony metastatic disease, that lutetium 177 would be bone marrow toxic. You know, my personal experience having a few patients on the study, it didn't seem like the bone marrow toxicity was that significant, but obviously from the trial data, it looks like it can be. I think like radium, like with a lot of time, that could be somewhat reversible. But I think that's an excellent question. And that may be one of the reasons that it's also being looked at an earlier disease states. Um, and I guess I don't know how well this is backed up by data, but my feeling is that PSMA expression may actually go down when patients become very late stage, like a neuroendocrine setting. Honestly, I'm not sure the data on that, but that's my sense is that those with PSMA negative disease are even more likely to have aggressive sort of FDG positive disease. Um, but so that, looking at an earlier disease state, I think I referred to the PSMA addition study, which is metastatic hormone sensitive. There's also PSMA4, which is progressive CRPC, but pre-chemo. So patients getting, going progress on ABI, going to ENZA, and then with or without the lutetium 177, that kind of scenario, something like that. So my gut feeling is that we'll see even bigger benefit there. Obviously, there's a lot of separation in those radiographic progression-free survival curves. So it's very exciting, but there wasn't really a tail on the curve. And the overall survival improvement of 4 months, while good, is not amazing. So I'm hopeful that maybe we can get more bang for our buck in these earlier disease settings. We'll see how that goes.
Yeah, I mean, the toxicity, the merotoxicity is an interesting question. I think, we're working with one of the radiologists at WashU, Dan Thorek, who his lab actually kind of specializes in these targeted therapies. And they, we've done some post-radium biopsies looking at the dose distribution in metastatic lesions. David, I don't believe in vision. Don't think there were any like biopsies in vision, right? I mean, so one question is, as as a targeted therapy compared to radium that is just kind of pan bone, what is the dosimetry that's actually being delivered to these sites? And I think that's probably, at least for radium, we don't exactly know. And my guess is for lutetium, we probably don't actually know that either.
Yeah, and I would imagine dependent on where the disease is, where it's located, and or the PSMA expressing disease. Yeah, yeah, good questions. And hopefully we'll learn more as there's more sort of subset analysis or additional analysis of this data. Hopefully we'll learn more about that. So I think the next question is for you, going to renal cell. How would you pick the regimens in first-line metastatic clear cell cancer? Pembro plus
Huh.
axitinib versus Pembro plus lenvatinib versus Nivo plus Ipi versus Nivo Cabo, in favorable versus intermediate risk groups. It's getting crowded with response rates almost very close. Very good
Yeah.
question, $1 million question. What's the answer?
There we go. Flip of a coin. Yeah, I think there have now been a lot of PowerPoint slides and charts, and the classic cross-trial comparison. And while there are some subtle differences between percentage of IMDC favorable versus intermediate poor, and subtle differences between the trials, I think the bottom line is that there, right now, in the absence of a first line head-to-head combination trial, you can't be wrong picking any one of those things. And they all use sunitinib as the, I would say now, kind of straw man, for a first line trial. And so I don't know. I mean, we we were involved in a couple of the trials. We have more experience with Cabo-Nivo. We were involved in the 9ER trial. And so I tend to favor that just because I'm more familiar with it. You could take another kind of follow-up question to that is, okay, fine, we have these great frontline combinations, but what am I going to use second line if I've used my best agents frontline? And that's also a great question. Some people could make the argument to do IO, Ipi-Nivo first line, and then save a Cabo based, either Cabo alone or Cabo-Nivo. If you could get that, there's an ongoing clinical trial looking at that, the Cosmic 3 trial. But you could also then do a lenvatinib everolimus in second line, which has a fairly good response rate, although the toxicity is not small. So I don't know, David, what are your thoughts on picking?
Yeah, well, it's a great question, and I tend to agree with you that there isn't a wrong answer. I think if there's sarcomatoid features, sort of very high grade, that tends to push me more towards Ipi-Nivo. First line, hoping for a good immune response. I think the TKIs are not as effective then, although I don't know that the TKIs plus immunotherapy aren't going to be as effective. But that's what my practice tends to be. That'll push me more towards Ipi-Nivo, and otherwise, I do think um, axitinib, avelumab, I don't really use as much. Pembro axitinib, I started off with, so I have a lot of experience with that. I do kind of like Cabo-Nivo. I do think that the data Pembro lenvatinib looks quite good in terms of response rates. I think there's frequent dose reductions, although Cabo can be a little bit difficult as well. And I've seen a lot of transaminitis with axitinib as well. So I don't think there's a clear winner there. I think all of them are totally reasonable. And I guess I agree with your approach. Go with what you're familiar with. And I think all of them are good options.
And
Um,
what with the recent approval of tivozanib, what where do you throw that in there now? I mean, that's a good second, third plus line option.
yeah, I don't have as much experience with that, and actually, so that's I don't know. I'm just kind of out there in the mix, and it may depend on what I can get approval for in the second line setting. I often try for another first line combination therapy in the second line setting, trying to switch up agents if I can get approval for that. But yeah, I think it's as you said, if you've progressed on a TKI immunotherapy combo, then where do you go from there? I do think lenvatinib everolimus makes sense. It's a good option, but
Yeah,
um,
I mean, I think we, as discussed, have especially in kidney cancer, geez, compared to bladder and prostate, really have so many agents, but a real lack of, I mean, the trials obviously take some time to do, but we don't have a lot of the head-to-head data with the new combinations that will answer these questions. So,
yeah.
oh,
Yeah, we won't. So you just kind of go with what makes sense. I think we're heading towards having to wrap it up. There was one more question about the role of cytoreductive nephrectomy in the era of multi-kinase inhibitors. I think that's a very good question. There is a cooperative group study that's open now. I think it's Probe is the name of it. although don't quote me on that. But it's open for folks who have gotten some kind of immunotherapy containing combination therapy frontline, and as long as you're doing well after 12 weeks, randomized to cytoreductive nephrectomy or not. So we'll wait the data from that. I think that will be very interesting data. Could really change the way that we do things. But I think that's about all we have the time for. But thank you all very much. We now have a quick break. There's still time to earn points towards the Engage and Win giveaway by chatting with our industry representatives in the exhibitor hall. Within their booths, you'll find helpful resources and information, as well as the ability to talk now with an available booth representative. Thanks all.
Thank you, guys.